strain are very low, and in this way we probably miss most of the evolutionary history and the place of importation of the dengue viruses in the West African country. According to recent estimate in the global database like GeneBank, only 1% of all available dengue genomes are from Africa. This highlights the urgent need in order to increase the number of genetic genome, and this will help us to design appropriate countermeasures against the circulating virus variant in the country. And beside also this aspect related to the detection and the genetic characterization, we try to understand what can be the impact of the genetic diversity of the viruses that we are detecting against some countermeasures like vaccine that are used for clinical trial. And then we compare the viral strain that we are detecting in Senegal from 2018 to 2023 against the two candidate vaccines, the dengue vaccine and the tetravax. And what we saw, it is they are some amino acid change in the K position. This means the position that are associated to immunogenicity against this vaccine that are now used for clinical trials. This means probably most of the vaccines that are now used in Asia or elsewhere can be not effective to be used in the African context, and this probably call for the development of tailored vaccine that take in account the circulation of the dengue strain that we have in Senegal. And also we mapped the amino acid change that we have against the viral domain in the flaviviruses, and principally in our exam for dengue, we have three domains on the E protein that are the main component in the human response. And then we saw that most of the amino acid change that we are facing are located in the domain 3. And we know that this domain is very, very active in the neutralization step of the viruses. And also the last aspect that we are trying to dive into, it is what are the genetic diversity of the viruses that we have against the human map that are produced by the B cell epitopes after the infection of dengue virus 3. And we saw that they have 3 case mutation that we did not found in any other sample of sequence that we have from the world. And the second aspect that we want to share some data with you, it is the reemergence of the dengue virus 2 genotype 6, namely dengue salvatic 2 in the southern part of the Senegal. In the past, most of the epidemic of dengue that we face was linked to the salvatic cycles. And up to 2009, we show a shift from the salvatic circulation of dengue to the urban circulation of dengue. And in 2020, we face 1 cases of the dengue infection that was collected from Sarayoba in the southern part of the Senegal. The patient exhibit a clinical picture of the dengue infection with symptoms ranging from cephalia, arthralgia, myalgia. And then the patient sample was collected 2 days after the sample onset. This means we was in the acute phase of the dengue infection. And then when we tried to test this sample by PCR, we saw that the sample was positive for dengue with a higher CT value lower than 24. But surprisingly, when we try to serotype the viruses, all the serotyping attempts fail, despite the higher viral load that we have inside the sample. And then we are facing a situation where we lost a certain logic. And then trying to decipher why we are facing this situation, we just use set of primers that are designed for flaviviruses that targeting the NS5 regions. These primers have the particularity to be able to amplify a portion of the NS5 gene of all the flaviviruses. And when we sequence this portion using nanopore sequencing, the blast results show us that we were facing an infection related to the dengue virus 2 genotype 6, the salvatic strain. The one that we detected the last time during 2019 from a tourist that traveled across Senegal and across Kolda and Guinea-Bissau, returned to Spain and was diagnosed to have dengue infection. And then from this blast result that we got from the NS5, we use back the blast result and then pick the 15 genomes that are closer to our strand. And then using this whole genome sequencing, we design a new set of primers in order to be able to amplify the whole genome of the viruses using tiling PCR. And this approach allows us to get the full-length genome of the viruses that was detected in Sarajevo. And then using also the set of primer that was previously used for characterize dengue virus 2 and our tool that we designed it before, we were able to see that why we missed to amplify properly the genome of the dengue 2. It is clearly here shown that most of the primers that we are usually using in the past to characterize dengue virus 2 have a higher level of mismatches against this re-emerging sylvatic dengue virus 2. And this call for the need to design new set of tools that allow us to amplify properly the full genome. And then we compare this design with the other previous tool that was designed for dengue viruses 2. And then we show only the new design were able to give us a higher coverage and a higher depth of coverage across the genome for all the dengue virus sylvatic 2 that we are trying to characterize. And then after we go back to understand why we were unable to identify the serotype of the dengue virus 2 using the molecular tool that we are using to define the serotypes. And using the same in silico approach, we found that most of the primers used to characterize dengue virus 2 exhibit a high level of mismatch on the primer binding regions, principally the primers that are related to the probe, because it is known that the last 5 bases of the probe, if you have a mutation there, this is detrimental for the perfect amplification of the viruses. And then we design an updated tool that match with the sylvatic dengue 2. And then we evaluate this tool in comparison in singleplex and in multiplex. And we show that in the figure below that this tool is able to detect the dengue virus 2 sylvatic strain at the same level in singleplex and in multiplex, and the limit of detection is up to 5 copy per microliter, 100 copy per microliters, showing a high level of sensitivity of our assay. And then this tool can be a tool that we can use in near future to understand what is the level of circulation of circulating dengue viruses just by doing one PCR instead of going up to the sequencing to understand what is the real prevalence of the virus in the community. And according also to the tools that we designed to characterize more dengue virus to sylvatic strain, we are generating more full whole genome of the viruses and try to understand what is the level of use of the codon edges using this virus strain. And we show that in the figures, there are some colors that are lost, that sylvatic strain in the left side and the urban strain are not using in the same level the codons to translate their protein. This means they are a kind of signature that differentiate the level and the use of the codon between urban and sylvatic strains. And then here we just drive down a correlation between the codon adaptation index. This is a proxy in order to understand how the utilization of specific codon can match with the usage of the codon on the host that was infected by the viruses. And in the y-axis, you have the chi index for the Aedes aegypti, the main vector of dengue viruses. And in the x-axis, we have the chi index for the human. And then what we saw here, this is the of lower level of correlation between these two chi, meaning that there are many parameters beyond the genetic makeup that are impacting the emergence of the dengue sylvatic strain in the community. And then we map the temporal trends of the codon adaptation index against the Aedes aegypti and the Homo sapiens, and we saw that they are clearly a lower adaptation of sylvatic dengue viruses against Aedes aegypti, and the same result was observed by the entomological teams in the previous work using vectorial competence studies. And then we have also a higher level of adaptation to human. This means maybe the emergence of the sylvatic dengue in human can be maybe linked to the fact that they have a lower adaptation to Aedes aegypti. This is one of the parameters that need to be taken into account. This means overall that they have still room of adaptation and improve its transmission among the Selvatic dengue through in the country. The third project that we want to share with you, it is in May 2024, we are in the situation that we detected a dengue cases that was imported else from a specific country. And then when we collected these samples, we tried to do all the process are presented before, going from the detection, the serotyping, and the obtention of the whole genome sequencing data. And then when we perform the sequencing, we observe that the strand that we are detecting and we were able to characterize the nearly complete genome is a strand of dengue viruses that belong to minor lineage dengue 2 cosmopolitan genetic F1.2. The particularity of this minor lineage, it is the lineage that is only reported in Brazil. And then when we combine the data that we have from the genomic characterization of the strand and the epidemiological data, we saw that the viruses that the strand that we are detected from the patient that say in the form that he traveled from Brazil. This means in some point, genomic data can be something that can complement the result and the parameters that we take in account using just epidemiological data. And then the problem here is in the context of the situation where we are showing the rise of the Oropouche virus in Latin America. The question is, what about the situation of the importation of Oropouche in Senegal or in Africa? Does it mean that we have the same probability of the viruses to be introduced in Africa? And as a recommendation, we think that we have to be prepared for the maybe exportation of the Oropouche in Senegal. The fourth project where we are running, it is about the expansion of the lesson that we're learning in the genomic characterization of dengue in West Africa. As raised before, only 1% of the genomic data are from Africa, meaning that we need to train many of the countries in order to be able to do real-time genomic characterization of the circulating strand. And then this is thanks to the project that is called RELSINET. It is just a project that aims to perform an extension of the syndromic surveillance program that allow IPD to detect up to 14 epidemics. And then the project was implemented in Cabo Verde in 2023. And 3 days after the implementation of the project, the country was able to detect the re-emergence of dengue viruses in the country. And then after, we received a letter from the Institut National de Santé Publique of Cabo Verde to be helped by IPD to implement the diagnostic, the serotyping, and the genomic characterization of the strand. And then we were in Cabo Verde in order to implement this diagnostic, and we have the possibility to generate our first 11 nearly complete genome of the viruses 1 day after the deployment. And then this helped us to characterize the viruses that was circulating and was responsible of the outbreak in Cabo Verde. And then in terms of occurrence, most of the cases were located in the Fogo Island, where it was the epicenter of the dengue virus's transmission around the archipelagos. And on the genomic level, we saw that the viruses is belonging to the dengue virus 3 genotype 3 that have the particularity to be a genotype of the viruses that are associated to high transmissibility. And then according to the time tree that we are generating and the length of the branch, we saw that most of the evolutionary history of this strand are probably lost, maybe due to the fact that there was any surveillance program that was in place in the archipelagos. And now from dengue, we shift to chikungunya viruses with the cases that we are facing during the outbreak in the southern part of the country in 2023. We have a chikungunya cases that we were able to detect properly using our in-house method that we developed years before to detect chikungunya. And then we tried to see what can be the level of detection that we can find using a widely used CDC trioplex assay that was developing during the outbreak of Zika in Brazil. And this tool was able to discriminate dengue, chikungunya, and Zika. And We noticed that when we tested the same sample using these two tools, our in-house was able to detect the viruses with a good CT value. And using the CDC trioplex that is widely used, we have a lack of detection of CT value of 7 delta CT, meaning that this tool have lower level of sensitivity to the West African genotype. And when we perform in silico analysis, we saw that there are also some mutation that rising in the primer binding region, principally in the probe. And then we decide to develop a new set of primers that take in account all the genetic diversity of chikungunya that we have using the new genome that we generated during the outbreak. And according to this figure, we saw that the three tools were able to detect the viruses at the same level when we are dealing with the Exa genotype and ASEAN genotype. But when you are dealing in the West African genotype, the trioplex CDC was able to detect the viruses with a loss of the sensitivity, and our new design was able to bring back the sensitivity of the tools at the same level that we got using our in-house assay, and with the possibility also to multiplex him in order to detect differentially chikungunya, dengue, and Zika. And then the sixth project that we are evolving and trying to understand what are the parameters related to the low level of genome coverage of chikungunya West African genotype using a previous scheme that was used to characterize the viruses. Using our tool, we saw that these viruses also exhibit a high level of mismatches against the previous tool used to characterize chikungunya viruses. And then we decide to design a new tool that is more adapted to chikungunya West African genotype that was responsible to an ongoing epidemic in 2023. Our new tool was able to sequence the nearly complete genome of the viruses in different platforms, going from Illumina approach or nanopore sequencing using both short reads or long reads, meaning that we have a tool that can be able to be used easily according to the platform that you have in hand in order to characterize in real time the virus strain that was circulating. And the new tool allow us to characterize a chikungunya strain that we are detected in Gambia in 2023. And according to phylogeographic inference, the viruses that was detected in Gambia was imported to Gambia from Kolda with a higher confidence, meaning that it is very important in order to be able to do coordinated response and outbreak investigation between the neighboring country, because these viruses have the capacity to spread and cause epidemic in neighboring countries. Finally, as take-home message, detecting and tracking change in the viral makeup and the arboviruses is something that is very important in order to identify increases threat and the incidence on infection. It enables to organize and have appropriate public health response and assess the effectiveness of intervention. Also, dengue is a public health problem, and the first case of dengue was detected in Senegal in 1917, and for years there is little that was known about the genetic diversity of circulating strain. And despite also the association of dengue to epidemics, we have a low level of characterization of the viral strain, and leveraging nanopore sequencing, Illumina sequencing, in silico approach and bioinformatics, we was able to characterize in real time and study the genetic diversity of circulating strain. Also, according also to the genome that we got, we was able to assess the impact of this viral diversity on diagnostic and countermeasure like vaccination using still in silico approach. This means we need to go further from this in silico data to understand what really happened in the in vitro level and in the infected patient. And then finally, learned lesson in dengue was expanding to other arboviruses like chikungunya and share it also at the sub-regional level in order to strengthen the response to epidemic and the better understanding of circulating strain. I would like to acknowledge some people that are helping to make this work. And if you want also to learn more about all the work related to arboviruses, you can just scan the QR code and access to the page that can show you some results on our research. Thank you so much for your attention.
Yes. Thank you, Idrissa Dieng, for this wonderful talk where you unpack the genetic toolbox for arbovirus surveillance, helping us characterize the pathogen, to track existing and new variants, and to also inform the development of new countermeasures. Thank you for your talk. Before we move on to the next speaker, I just have a quick announcement. There are some participants who signed up to visit the campus of IPD. If you're one of those who signed up, please make your way to the registration outside, where there'll be a bus to take you to the IPD campus for the tour of the campus. Thank you very much. So our last talk for this day's symposium is from Dr. Marta Fernandez, who is joining us online. I just want to make sure that she's connected. IT. Great. Hi, Marta. Nice to see you. So let me quickly introduce Dr. Marta Fernandez. Dr. Marta Fernandez is a global health executive spearheading innovation and transformation in healthcare. With over 15 years of experience across academia, industry, and global health institutions, she focuses on developing diagnostics and digital health technologies to improve health equity worldwide. She holds a MS in chemical engineering from Institut Pasteur de Dakar and a PhD in biochemistry from MIT. Dr. Fernandez, welcome, and the stage is yours.
Thank you very much, Carol, for the introduction. And thank you very much to IPD for inviting me to present here today. I am really sorry that I cannot be in Dakar today. I am actually arriving tomorrow, and I look forward to seeing you all in person soon. I know it is late, and you all need to let your brain rest. So for now, I'm going to try to present a presentation that will allow your imagination fly. And I'm having some issues sharing, but I'm going to start sharing very quickly. Excellent. Please let me know if you can now see the screen. I believe you do.
Marta, excellent. We can see your screen.
Excellent. Thank you, Carol. So as I said, it's late in the day. Many of you want to go see the IPD campus and also just take some rest. So put your brain aside. You've seen a lot of extremely rigorous and interesting and critical presentations today on the science, and now we're going to let our imagination fly. So, here we are in Dakar. I will be there soon, and we're thinking about reaching those remote populations, those populations that are in the background. And, we often think, shouldn't we stop talking about hard to access population? Instead, why don't we flip around and we bring the people to the background? So it is not the people that are hard to access, but instead we talk about remote, hard to access healthcare systems. So in our current healthcare systems, people need to walk for very long distances to reach the healthcare. And in this picture, obviously it's an AI-generated image, so it's not representing any particular setting, but it's pretty reflective of what happens. We have a city and a hospital at the top, and we see people that are walking from very different areas towards that hospital. There is also a clinic in the middle to the right. There is a health post at the top bottom, so really in the foreground, with a lot of people waiting. And we can see that all of those people that are walking are trying to reach the care they need. And many of them don't make it. Many of them request referrals because at the health post, there may not be a health practitioner that has the training needed to provide the care they need. They may not have the diagnostic test they need. So they keep being referred to higher levels of the healthcare system. And along this path, many of those people are lost because they either never get that test or that care they need, or they are lost to follow up. They may reach to the hospital that one time, but then they cannot be found again. So what if instead of asking people to walk, we ask the tests to walk to the communities? And they could work through, mobile teams. I know many of you have been working on mobile teams, have been working on decentralized testing. We need to do more of that. And now we can actually do this, and we can start letting go some of those trade-offs that we have been thinking about for many years. So I'll walk you through some of that, right? But just imagine we can bring every single test we can into a health post, or every single test we can action on. Of course, there is always going to have to be a compromise and a healthcare system that is has a network that is complementary both in decentralized settings and decentralized. And when the tests travel, then what travels back and forth is the data, not the people. So now we have systems that allow us to really communicate across all of these different levels of the healthcare so that we can truly utilize the high potential of these rapid diagnostic tests. So now stay with that setting, right? That setting where we have tests that travel to the communities, data that goes back and forth, and people who can access the care they need where they live and where they work. So these are healthcare settings that are community-based, that are people-centered, right? They meet people where they are, and they access people early in the care pathway. And this is critical in so many cases. And I'm going to explain to you a couple of examples. And importantly, and I want to emphasize this, I believe that by moving healthcare closer to where people live, we'll have more chances at achieving integrated, more holistic horizontal care in a way that we have been struggling for years to get horizontal care in tertiary settings. And for a very good reason. We need efficiency, we need other things. So by having a system that complements that centralized settings that are efficient, that can be very specialized with less specialized horizontal care in the communities, we can really transform how people get care. So I'll provide a few examples. And I could give examples of COVID, of course, of the power of rapid diagnostic testing during COVID. During MPOX, we're seeing the lack of decentralized testing is really hampering our response on the MPOX outbreak. But I'm not going to provide examples on emerging pathogens or pandemics. I know, Dr. Maria Van Kerkhoff, as well as Dr. Tulio de Oliveira, spoke to you earlier today about many of the use cases and the needs during pandemics. So today I wanted to give you examples of other health priorities, of some of these diseases that are affecting the continent for many years, and yet due to the complex epidemiological context, they are still a challenge for disease control. So one of them that I wanted to talk about today is sleeping sickness, human African trypanosomiasis. And really the reason why I want to focus on HAT is because rapid tests have truly transform our elimination programs on HAT. So as I'm sure many of you know, human African trypanosomiasis is a vector-borne parasitic disease that is transmitted by humans by the tsetse fly, and it's mostly prevalent in sub-Saharan Africa. And really for many years, over the last 20 years, sustained control efforts have reduced the number of cases by 97%. Yet, reaching elimination proved extremely difficult. And really, rapid tests have played a key role in achieving elimination because they were able to expand the access to the passive screening that was part of those control programs, and they were able to be utilized in a much more effective way in active case funding through the mobile teams. So if we look at what the HAT status is today. On the right and the bottom, you can see the number of new reported cases. So very few cases are being reported. Many countries are not reporting cases. And very importantly, just in the last 4 years, in 2020, WHO has validated the elimination of HAD as a public health problem in 7 countries for Trypanosoma gambiense, and one of them for rhodesiense in Rwanda. And I must note that this rapid test can only works well for gambiense, for Trypanosoma gambiense. So this test, and we need to understand the timelines. It was started to develop through a collaboration between FINE and SD Bioline, who is now Abbott, back in 2013, and together also with the Institute of Tropical Medicine in Antwerp. And it has taken about 11 years since the time that this test was envisioned. Then it was developed, then it was manufactured, and then it was made available in the country through pilots and then a scale up, and is now a core element of elimination programs. And again, has allowed elimination in 7 countries. So a great example of really the power of rapid diagnostic tests. A second example that I wanted to highlight for a slightly different reason is visceral leishmaniasis. But really here as well, rapid tests have been key to advances towards disease control and elimination. Visceral leishmaniasis, I'm pretty sure you also know, is also a vector-borne neglected tropical disease. Now, in contrast to HAD, to human African trypanosomiasis, VL still has a pretty high incidence, estimating between 50,000 and 100,000 cases a year, new cases a year. And it has a much broader geographical spread than HAD. Is present in Asia, in Africa, as well as the Americas. I think Leish exemplifies both the critical role of rapid tests and also the limitations that it had. So if we look a little bit at the timelines, about almost 20 years ago, Bangladesh, India, and Nepal, which together account for 70% of the global burden of disease, launched a regional CALASAR, so visceral leishmaniasis, also called CALASAR, elimination initiative. And it was focused, among others, on early diagnosis and on the use of these rapid tests. And again, a huge success. Bangladesh has been able to eliminate VL as a public health program as of last year. WHO validated that elimination. A new framework has now been launched this year to promote the elimination of visceral leishmaniasis in Eastern Africa, with early diagnosis, again, as a key strategy. So one would think, why has Eastern Africa been slow? And I'm sure there are many other factors. I don't want to oversimplify, rather I'm just going to want to give you the point of view of the diagnostic test, and again, let us think through how we can improve. So when we look about these rapid diagnostic tests for visceral leishmaniasis, they are antibody-based tests. So they are looking for IgG, some IgMs against the RK39 antigen. They show a sensitivity of about 97% in the India subcontinent. Yet the sensitivity is only 85% in East Africa. And that decrease in sensitivity has really hampered, again, among many other factors, of course, our ability to identify cases. So this example, the HAD example is a tremendously successful example. So is VL, but the VL example is also exemplifies the need for that accuracy, the need for tests that are really able to support the clinical use case. So traditionally, when we think about rapid diagnostic testing, right, we see this balance. And this is a little bit of what we see with the VL case, where in the lab, in the central laboratories, we can have tests that are highly performant, right? High specificity, high sensitivity. They are in a controlled environment. So the laboratory technicians are highly trained. There are quality management systems in the laboratories, and they are integrated into the healthcare system. So the data is readily available from the labs by the healthcare practitioners, by the healthcare providers. In contrast, rapid tests are not connected, they are not integrated into the healthcare systems. And this has been a very large criticism from some of those people who really prefer a centralized systems. But they offer access. What they offer us is rapid testing, so very fast turnaround time within 15 minutes. So on the spot, a person can get the result. They are very low cost. And importantly, they are accessible. They can really reach people in the communities. And we have seen that this is critical for HAT in the example that I provided before, for VL, and in pandemics and in outbreaks is critical too, as it has been mentioned before. So now let's reimagine, right? How can we get those gains that from a rapid, low-cost, accessible testing, and yet do not have to fully compromise? There is always compromises, of course, but let's reimagine a healthcare system, and we're closer than we think, right? But what do we want? So we want decentralized tests that are low cost, that are rapid, that are quality assured. And I hadn't mentioned quality assured before, right? But many of the rapid tests today are indeed quality assured, thanks to many years and the effort of many people on ensuring that we have external quality assurance programs and others. So these are our rapid tests. But what else can we get today? We can get tests that have clinically relevant accuracy, right? And this is a thing where some of those trade-offs have come through. When we think, for example, about the COVID-19 pandemic, those COVID antigen tests were fairly accurate with a really high sensitivity. And in a sense, we often make the comment that we kind of lacked out because there were really high quantities of the antigen in the bodily fluids. We see, for example, with the Mpox outbreak, we haven't been so lucky. Really, the rapid tests for Mpox are not performing at the sensitivity that is required. And again, there may be innovations we can improve, right? But there are some limitations. So we can improve rapid tests, and we can also look at other decentralized testing beyond your standard lateral flow tests that are also rapid, that are also low cost and quality assured. So let's think, for example, about molecular testing, right? And I'm putting here a picture of the GeneXpert, and I just want to make sure that I read the disclaimer below. When I'm showing technologies in these slides, it does not represent an endorsement or a recommendation for a particular technology. I'm just representing a product class. So in this case, I'm representing what we've been calling near point of care molecular systems that have really been transformative for some diseases. For example, tuberculosis. These molecular tests can be deployed not just in very centralized laboratories, but a little bit lower in the healthcare system towards district labs. Now, they still cannot be used on health posts. They still require electricity. They require certain training and certain infrastructure. During the pandemic, there was a huge push and investment and innovation towards further decentralizing molecular testing. And again, I'm putting here an example, not an endorsement of this particular product, but we now have molecular tests that are really able to run in this device that you can see here. And you cannot tell, actually, the picture. I should have put it to scale. But that instrument that you see on the center of the screen right now is about the size of the palm of my hand. So really much smaller. It runs on batteries. It provides you very rapid results. It does have a trade-off in performance, right? It for some cases, but again, innovations are bringing that performance very close to what we can see on a near point of care system or what we can see in the central laboratory. We also need to think about what is the right use case when we talk about decentralized testing, right? Screening versus diagnosis. So perhaps these very decentralized systems cannot have really high multiplexing. It cannot really test for all pathogens you would want for a syndromic panel on respiratory. But they can detect a few pathogens that allows you to do diagnosis for a small number of diseases and perhaps screening in some other cases. So now, another example of clinically relevant accuracy that has really flipped our mind on what can be done in a decentralized setting versus not. We now have portable X-ray equipment. And we now have portable ultrasound equipment, and these are two examples that you see here. Not only they are portable, but they are also enabled with artificial intelligence that helps both with performing the test. So the software is able to guide the person who is conducting the test. So this does not need to be a radiologist or a sonographer. It can be a healthcare practitioner with a relatively short training, and this AI-enabled software that guides on how to do the test and the results interpretation as well. So again, we now have rapid tests that are lower cost, that can really be brought into decentralized testing, and they have a clinically relevant accuracy, so that an action can be taken and a clinical decision can be taken on the spot in these decentralized settings. So what else would we want in these settings, right? We would want connected tests. One of the big pushbacks against the lateral flow test, the very first rapid diagnostic test that were made, was that they were not connected, that the data was getting lost, that it was not being able to action, and that healthcare systems overall were not the most efficient or effective because they didn't have access to that data. So connectivity. Now, beyond just the standard connectivity and the connection of the data back and forth from the test, we now can also do through digital diagnostics enhance the way we work. So for example, this is an example of an RDT app that both guides the healthcare practitioner, the healthcare provider, on how to run the test, and it can also interpret the result of their tests to support, to facilitate result interpretation, and also to help with transmitting the data. But there are other digital tools that are going to become key tools for healthcare practitioners in decentralized settings, in point-of-care settings. For example, clinical decision support tools like the one you see on the screen now in the middle, that are essentially digitalizing the clinical algorithms to empower healthcare providers, healthcare workers, or others to really do triage and to understand what are the needs of that particular patient they are seeing. And they are guiding them through that decision support through a digital algorithm. And now we're looking that these algorithms can also be AI enabled and enhanced to really improve the accuracy and the effectiveness of those tools. And then just, if we go even further, we've been talking a lot about community testing, right? And I'm not going to get into self-testing here because of the limitations of time, but there are many other clinical digital tools that are supportive of self-care and self-testing. And this in particular is a chatbot that was developed during the COVID-19 pandemic. So we have tests that are low cost, that are rapid, quality assured, with clinical relevant accuracy and connected. And I do want to highlight, before we close for today, two other critical characteristics of those tests. One of them is that they are relevant to the local context, and that are available when and where needed. And the reason why these 2 points have become very important, and I think these weaknesses were really highlighted during the COVID-19 pandemic with disruptions in supply chain. So we can have the best rapid decentralized test in the world, but if they cannot reach when they are needed to where they are needed, they are not useful, right? So if there are supply chain disruptions, if there are import-export restrictions, and the tests are only made in a handful of regions in the world, in a handful of countries, they will not make it where we need it. Furthermore, if we want tests that are relevant to the local context, that are responding to the needs, to what each community needs, they should be made. They should be developed close to where they are needed. So there is a big push now for a new diversified model of innovation and production that puts the emphasis in conducting R&D and enhancing the capabilities for R&D and for production in different settings around the world. So just to close for the day, again, many advances in this front, and one of them particularly relevant for the audience today is happening at IPD today. And this is the COVID-19 test that was developed by the Institut Pasteur in Dakar during the pandemic and the Diatropics facility. And many of you may be able to see this week the new facility that has been built in the Embao site. So again, we're looking at tests that not only are low cost, rapid, they are clinically relevant, quality assured, and connected, but that they are developed and produced in the region, and they are doing so with quality assurance at scale. So with that, I just let you with this new image of what really rapid testing can do and how it can really transform healthcare systems so that we can start thinking about accessible healthcare systems and healthy populations. Thanks, everybody. And I wish you all a great evening.
Thank you very much, Dr. Fernandez, for this brilliant talk and for reminding us what we are here for is really to protect communities, those that are even hard to reach, re-centralizing the debate back to individuals and communities in our countries. So this is the last talk for today. This morning we started out with Dr. Van Kerkhove from WHO, who reminded us that there are many lessons to be learned from the COVID-19 pandemic and past pandemics, and that we need to leverage those lessons learned, capitalize on existing capacities to prepare for future pandemics. We then had Professor De Oliveira, who delved into the power of genomics. He described some of the initiatives around capacity building across the continent to really prepare the next wave of experts in genomics in the continent to prepare for the future pandemics. And we then had a panel discussion where we looked into more tools to really characterize these pathogens that are causing recurrent epidemics on our continent, serosurveillance, genomics, mathematical modeling. All these tools are available to us today to prepare for future threats. Dr. Fernandez ended up reminding us that communities also need to access these solutions. We need to focus both on solutions that are at the laboratory level, but also develop solutions that can access people where they need it the most. Tomorrow we'll continue with the symposium. So today we focused on tools to characterize pathogens to inform countermeasures. Tomorrow we'll talk about these countermeasures, therapeutics, vaccines, and diagnostics. And again, tomorrow we'll end on communities with a final panel. So thank you everybody for your attention. Thank you for joining us today in this celebration of IPD's centenary, and I wish you all a very good afternoon.